Let's see. Good afternoon, everyone, and thank you for joining the first session in our age-friendly geriatrics education tele-echo series, Enhancing Your Client's Health Check. This series has been organized for you by UC Irvine's Division of Geriatric Medicine and Gerontology in partnership with Meals on Wheels California. So thank you so much for taking the time out of your day today to join us. We have a lot to get through in this hour, so I'm going to go ahead and get us started.
Are we allowed to record?
It's being recorded at the moment, and we will be dispersing to Meals on Wheels California.
Okay, because I'm sure you're going to give us a ton of information that we can't write to record.
We'll definitely share with you all. Yeah, we're definitely recording right now.
Thank you.
No problem. So this is today's agenda. I hope you all can see the PowerPoint. This is the structure of our ECHO sessions, starting with announcements, introductions, followed by a quick 30-minute didactic, and then moving into our case presentation with collaborative discussion, and then followed with closing and reminders. Just to make sure the sessions run smoothly, please remember to mute yourself when you're not speaking to prevent background noise, and introduce yourself with your name and location prior to speaking, and then maintain confidentiality when you're speaking about your clients by refraining from including any identifying information, and then of course just respect one another and everybody's opinions. This series is approved by the California Board of Registered Nursing, and you will receive a CE certificate at the end of the series as long as you complete the CE form that will be sent to you in your email after each session. Certificates can be submitted to your licensing board for credit, and many CBRN CEs as transferable. You do have to attend the full hour for credit per session, just as an FYI. So just to let you all know what an ECHO is, this is the format of training we'll be using for this series. So Dr. Sanjeev Arora started Project ECHO in 2003 at the University of New Mexico because he was frustrated that he could only serve a fraction of his hepatitis C patients in the state. So he created a free educational model and mentored community providers across New Mexico in how to treat the condition. So that ECHO model has spread, and there are hundreds of hubs around the world, and hundreds of practitioners and community providers who have received specialized training and have been able to impact thousands of patients and clients that have been reached with this specialty knowledge and expertise. So here at UCI, we have an autism ECHO, and then we're the specialists for our geriatrics ECHO. So as you can see from this graphic, it's really a collaborative, interactive learning model consisting of a hub team, which is the host, and that's us from UCI, who specializes in geriatrics, and then the spokes, who are you all today, from Meals on Wheels California member agencies, who have an interest in the care of older adults. So the interactive part of an ECHO comes from participants submitting cases for discussion, and as a group, including the spokes and the hubs, we have discussions about the case. So you'll get to see our first case discussion towards the end of this session. Our series is a part of HRSA's Geriatric Workforce Enhancement Grant at UCI, and we want to thank Daryl Turtle of Meals on Wheels California and Holly Hagler of Meals on Wheels Orange County for their partnership. One of our goals for our grant is to provide education and training for older adults, caregivers, and families through partnerships with community organizations, and you all are definitely a part of this geriatrics workforce. So we truly thank you all for all the work that you do, especially through this trying year. So thank you for being here today. So in every ECHO, we usually like to have everybody take the time to introduce themselves on video, but since we have so many on the line, which is a great thing, we'll go ahead and have you all introduce yourself via the chat function. So if you know how to use the chat function, please go ahead and list your name, your role, your site, and location so we can all just see who's here today. And then as you do that, we'll go ahead and have our hub team introduce themselves on video so you can get to know us. I will go ahead and get started. My name is Nika Seville. I'm the GWEP project manager here at UCI Health, and we're located in Orange County, California. So we can move on to Dr. Gibbs.
Hi, everyone. I'm Lisa Gibbs. I'm the division chief for geriatric medicine at UC Irvine. Thank you for being here.
and Dr. Sagel.
Welcome, everyone. I'm Sonia Sagel. I'm an internist and geriatrician in the Division of Geriatrics at UC Irvine. Welcome.
Thank you. And Geraldine.
Hi, my name is Geraldine Date. I'm a licensed clinical social worker in the Senior Health Center at UC Irvine in the actual Senior Health Center practice here. Nice to meet everybody.
Thank you, Geraldine. And Carlos.
Happy Friday, everyone. My name is Carlos Garcia, and I'm the data analyst for our Geriatric Workforce Enhancement Program. Welcome.
Thank you all. And I see a lot of people introducing themselves from San Francisco, Sacramento, Long Beach, Alameda, San Diego. It's wonderful all here today. Again, thank you for joining us. So we only have a quick hour, so I'm going to go ahead and move us into our didactic presentation. And that is going to be focusing on COVID-19 long-term effects in older adults, presented by Dr. Lisa Gibbs, who's the PI of our GWEP grant and chief of the Division of Geriatric Medicine and Gerontology and medical director at the UCI Senior Health Center. If you do have any questions along the way, please feel free to post them in the chat function or save them until the end of the didactic. And we'll go ahead and get you started, Dr. Gibbs.
Thank you, Anika. So good afternoon, everyone, and welcome. Again, we are very excited to be presenting the first ever Echo series for Meals on Wheels, California. Again, as Nika stated, I'd like to also thank Daryl Turdwell, the executive director, and also Holly Hagler, the CEO of Meals on Wheels, Orange County. We've had a long relationship with our own Meals on Wheels, for which we are truly grateful for. As noted, this is the kickoff presentation for this series, and as requested, this is the topic is the long-term effects of COVID-19. Next slide, please. So let's start off with some data in terms of the effects of COVID in California. And if you'd like to reference this for yourself in the future, this is from the COVID-19 California.gov or ca.gov website. In terms of California statistics, as of last weekend, we had 3,614,112 cases of COVID in California, and we had 59,690 deaths from COVID in California. So the California death rate overall is about 10% of the United States death rate of roughly 600,000 people. Thankfully, the COVID rates in California have declined significantly over the past few months. And even within our own hospital at UCI, we only had one COVID patient in-house in the last couple of weeks. So even though we had an awful surge in the beginning of the year, we are doing much, much better at this point. Next slide, please. However, we need to look at how this has affected our older adults. We know that COVID-19 has had a major impact on everyone. None of us will ever be the same. From our activities, our routines, our livelihoods, our mental health, our well-being, and especially for our seniors. So although all have suffered, really the pandemic has been particularly deadly for older adults. This is a table from the same website showing the distribution of confirmed COVID-19 cases and the deaths, revealing significant disparities across California's age groups. As you can see from the chart, people with ages 18 to 49 have had a disproportionate number of cases. But if you look at the people over 65, they've had a disproportionate number of deaths. So if you look at the chart, although people over 65 have numbered about 10% of the total cases in California, they have accounted for 74% of the deaths. So clearly, truly older adults have carried the burden of death from this pandemic. Next slide, please. So we know, and we're starting to learn about long-term effects. The news recently shared that approximately 1/3 that survive a COVID illness have some type of lasting effects. And we're starting to see some of that in the scientific literature. Also, although most people with COVID-19 do get better within weeks to months of the illness, some do not. And the CDC and other experts around the world are working now to learn more about the short and long-term healthcare effects associated with COVID-19. We don't really understand why some people have long-term effects and some people don't yet. And we're still at the point where we're trying to describe what those effects are. But long-term effects in general are those that persist more than 4 weeks after being infected with virus. And as you can see from this slide, there are various names being attributed to this. Long haulers is probably the most common one, followed by long COVID-19 or post-COVID-19. Next slide, please. So long COVID-19 is a range of symptoms that can last weeks or months after first being infected with the virus, or it can actually appear weeks after infection, after someone has really resolved the illness. It can happen to anyone who has had COVID-19, even if the illness was mild, or even if they really had no symptoms. So you can imagine, sometimes diagnosing these problems can be pretty tricky. The effects that we see are either from whole body inflammation or inflammation to a part of the body, or actually direct effects from the virus on particular cells. And I'll go into that in a little bit. But if you look at this list here, and I won't cover all of it, but it does start with tiredness and fatigue, difficulty thinking, brain fog. And that brain fog is actually turning out to be one of the more common complaints. We've seen it in our patients. We've seen it in colleagues. In fact, one of our geriatrician colleagues in Orange County had a severe case of COVID, and one of his hobbies is building bonsai trees. And he told me that, whereas he could build the trunk of the tree with 3 wires in 5 minutes before COVID, it took him over 30 minutes just to try to wind 2 wires together after COVID. And it was seriously affecting his ability to concentrate at work. Other symptoms can be headache, loss of smell or taste. I think we all probably know someone who has strange smells. One person I know is smelling burning toast for no reason at all, for instance. So we know there's some direct effects of the virus on the sensory endings for our sense of smell. Dizziness, chest pain, shortness of breath is also very common. We're now following somebody an 80-year-old woman discharged from the hospital 2 months ago, who's still on 1 liter of oxygen that she cannot seem to do without. If she takes the oxygen off, her oxygen level is in the high 80s instead of over 90. And that's very, very common. People are complaining about shortness of breath or just not having the stamina that they did before. So there's a long list here. And I will just say that, if we're dealing with vulnerable older adults who have a lot of other issues going on, and then you add one of these, even tiredness or fatigue or difficulty concentrating or headache, you can actually see how this could really impact an older person's life to have these long-term effects. Okay, next slide, please. Other effects are called multi-organ effects. And one is called the multi-system inflammatory syndrome. And others are classified as autoimmune. So organ-specific effects could include, for instance, the heart. We know that the virus has affected the myocytes or the heart muscle directly. But if we have a compromised, heart or lung system, and somebody already has a condition of heart failure, for instance, they may never ever get back to their baseline of heart failure. So their heart failure, in essence, then is worse than before, for instance. In the lungs, we can have low oxygen levels, such as I just described, because of scar tissue. In the brain, again, we can have the brain fog. Some persons with dementia will experience worsening dementia, as well as other serious issues such as strokes and seizures. And COVID-19 is also known to cause blood clots. And even a lot of younger people that have been hospitalized with COVID-19 have had heart attacks and other issues related to blood clots. Okay, next slide, please. And finally, those that have survived hospitalization, or especially the ICU, might be experiencing a post-intensive care syndrome, which includes a severe weakness and even post-traumatic stress disorder, from being completely vulnerable, from having to experience intubation, even having a tracheostomy tube in their neck to be able to breathe, and being really very, very deconditioned. So any of these effects in an older adult can compound the other risk factors and vulnerabilities that older adults have and contribute to additional illness, and really even premature death. Okay, next slide. But in addition to the medical effects caused by the virus, what about the effects from living in a society that basically shut down? Like, what happened to our quality of life in quarantine now for the past year? How did it affect our older adults in the community, especially congregate living communities? There may actually have been no perfect solution to what we went through and are still going through in many, many areas of the country. But for some older adults, in hindsight, it turns out that the prevention was probably even worse than the disease. Next slide. So in order to reduce the rates of infection, our government's adopted various policies such as social distancing, social isolation, and quarantine. But the consequences of this, as we know, are especially hard on older people and people with pre-existing mental illness. Living alone, loneliness, and social isolation are well-recognized risk factors for anxiety, depression, and even suicide in later life. I currently have a patient that I saw yesterday who's literally dying from this social isolation. Pre-COVID, he was living in a boarding care home. His main support system was his daughter, and he was living in the home with his wife, who had dementia. Early last year, his wife passed away. Unfortunately, he has poor vision. He's extremely hard of hearing. And when we went into sheltering in place or quarantine, his daughter was not allowed to visit. So she was unable to visit for months, as is the case with many, many families that we all know. And unfortunately, he languished without her company. When she finally saw him this past month, she found him to be bedbound, with failure to thrive, barely eating. And so by the time I saw him last week, this was the state of affairs, and she had already called 2 hospice agencies. So when I say that we have patients who are literally dying from social isolation, I think we're only seeing the tip of the iceberg at this point. We know that isolation is the antithesis of healthy aging. And this is not news to anyone here. And I know that Meals on Wheels is just so important to addressing loneliness alongside food insecurity. Next slide, please. In terms of surveys and studies, this shows some data from the Kaiser Foundation. And this data was taken in August 2020. Overall, 1 in 4, 24% adults age 65 and over reported anxiety or depression by August of 2020, and a rate which had been relatively constant since the pandemic started in May. This rate is substantially higher than 1 in 10 or 11% older adults with Medicare who reported the same issues with depression and anxiety in 2018. So 11% to 24%. And then within that group, we see on this chart that there are subcategories of people who have even higher rates. So for instance, if you had an older person who lived alone, it increased to 27%. Women, 28%. The older person who was also Hispanic, 33%. If their income was under 25,000, it rose to 37%. And if our older adult was in fair or poor health, it increased to a maximum of 40%. So huge rates of depression and anxiety in our older adult communities, essentially everywhere. Okay, next slide, please. I wanted to talk just a moment about suicide prevention. We know in Orange County, I am a part of a mental health advisory board, and I don't have any hard numbers for you, even though I was told that we just don't have them yet. But we know that our rates of older adult suicide have increased. And unfortunately, I think that we are not unique here in Orange County. For some people, the joy in living is really spending time with friends and family, right? And when this is not possible, other challenges that people face, such as dementia or chronic illness, become even more burdensome for people. The risk for depression and suicide is still much higher because of the pandemic. And those working with older adults need to be on the lookout for signs of suicide intent or planning. And this slide just points out that there are specific points of engagement that tend to be very effective. One is healthcare visits. Well known that the majority of suicide completers have visited their primary care physician in the year before suicide. We think of suicide in the community, but there's a lot of literature coming out showing that there are very high suicide rates or just as high in long-term care settings. And we may not understand this because it seems like long-term care settings have a lot of staff and people that are eyes and ears for people, but it turns out to be true. People undergoing transition, such as moving from their home and their dwelling into assisted living, into a community setting, are at high risk, as well, of course, of those that are living in isolation. Next slide, please. Some other effects worth noting. There are some studies suggesting that new diagnoses of dementia are higher in people that have had COVID-19, the long haulers, so to speak. But the consequences from isolation on persons with dementia have been devastating. In our own practice at the Senior Health Center, we've all been shocked to see the cognitive decline in people with dementia. Both people that have been living in the community and in congregate living. For instance, one of my patients in a very good assisted living facility in Orange County with mild dementia pre-COVID was quarantined to her room, just like everyone was. They would, so social activities were non-existent. The food was left by or pushed under the door. And people were just basically left to their devices inside their own rooms. So when her daughter was finally able to visit again after months, she was shocked to find her room in disarray, her mother with poor hygiene, and really, very confused. So her decline, by the time I saw her in the last couple of months, was much, much faster than I would have predicted for anyone with mild dementia. And at this point, she's moving into moderate to advanced dementia stages. Okay. In terms of physical conditioning, many have become less active. I mean, almost everyone, affecting weight, worsening conditions such as arthritis, balance, increasing a risk of falls. We know that the gyms, the swimming pools, the exercise classes all ceased. And physical condition is absolutely so important because we know that people that start to become less mobile age faster. People that become less mobile are less steady. People fall more. People that fall more have more injuries. And it becomes a downward spiral and decline. So physical conditioning is really very important for maintaining function and fall prevention. And because of this, we predict to be seeing an increased numbers of falls in our older adult populations in the next year. Also, I wanted to mention bereavement. I mean, many older adults, aside from the illness, have lost friends and family, especially those living in facilities where COVID has spread through communities. How many have said goodbye to families, to spouses, to roommates, to their social support system in the communities? We don't know. I mean, we could have people living in assisted living that lost a number of friends because of the pandemic. So I think we need to be especially sensitive to, issues of grief and bereavement. The trauma also of knowing that loved ones died alone in hospitals, without family and friends is haunting many of our patients and older adults. And, with the death rates high in communities, again, many are experiencing multiple losses in these situations. So I think the trauma stemming from this is something that will need to be addressed. The other thing I've noted, at least in my own practice, is how many of our patients have lost children, whether by COVID or other chronic disease during this time. And not only is this somewhat surprising, but it's really concerning, not only because our patients are grieving, but because many of our patients are losing their support systems and their living companions when their children die prematurely. So this is something else to keep in mind. And finally, it's noteworthy that, at least in Orange County, and probably everywhere, the elder independent abuse reports to our adult protective systems severely declined over the last year. I wish that we would be happy about that, but actually we're very suspicious about that, and we're waiting for the repercussions this year from a year in isolation, because we know that many continue to suffer and many will have suffered abuse and neglect, but just hidden from public view at this point. Okay. Next slide, please. So, for example, you can imagine one of the patterns we see in elder abuse. We may have caregivers with inadequately treated mental health or substance abuse issues who feel burdened and resentful and are really caring for an older adult who can be physically combative or abusive, and then you add COVID-19 with all of its stresses, whether it's isolation, job loss, increased other stress, food insecurity, etc. So basically, we're just pouring fuel on what's already a burning fire. Okay, next slide, please. COVID has also forced us to double down on efforts to address social determinants of health. We all know what social determinants are. They are the conditions in the environment where people are born, live, learn, work, play, worship, and age, affect a wide range of health functioning and quality of life. And the COVID-19 pandemic has only exacerbated these social determinants of health gaps, especially for our older adults. For instance, as Meals on Wheels employees and volunteers, you know very well that the dramatic increase in need for meals has just been astronomical. And we've discussed this in Orange County. And the reasons for this are likely multiple: the ability to afford meals, or no transportation to the grocery store, or afraid to go to the grocery store to get food, increased isolation, or loss of caregivers to bring food. So this has been a hugely dramatic change. And the questions still remain about what the post-COVID needs will be for food insecurity, as well as all of the other social determinants of health. Next slide, please. And to name just a few, we realize, again, that there are more financial stresses as people have lost their jobs, even for older adults who still work or for the families that they rely on. The digital divide has become we've become very aware of digital divide issues because the access and the resources for these social determinants are often found online. And I'd like to also focus on caregiving. Final point. We've seen a destabilization of our caregiving networks. Okay, next slide, please. Okay. So the inability to continue caregiving in many cases during this pandemic has been devastating. First of all, we are extremely concerned about, keeping older adults safe, not exposing older adults to others who don't live in the same household, but who may be coming in through IHSS or family, friends, and neighbors from other households. So all of a sudden, families just said, no, we can't have you in our homes. So caregiving was curtailed. Some families prevented, again, the paid caregivers from continuing to come in and helped. And this puts more stress on family members themselves. In addition, delays and disruption to medical care has been a real issue for both caregivers and clients. I was on call earlier in the pandemic, and a gentleman called who was a caregiver for his wife with symptoms that were very, very concerning. And I advised him to go to the emergency room. But he refused. He said, I can't go because what if I get exposed to COVID and I bring them home to my wife who has dementia? There's no one else here to care for her. So we could see that caregivers have experienced extreme situations that they've had to deal with. Okay, next slide. Okay. So we can see that the usual support systems, the outlets have not been available. And not to mention the closure of senior centers, daycare centers, those areas of social stimulation, which are so important for mental health and cognitive health, have not been available, and also has radically changed the lives of the caregivers who depended on those to be open for their older adults. Okay, next slide. So we need to start moving in and talking about recovery from COVID-19. COVID-19 has presented unprecedented health challenges throughout society. And now at least we can be hopeful that the pandemic is slowing in California. We can turn our attention to recovery, which no doubt will last much longer than the pandemic itself. So we know that the transmission may end with a vaccination campaign, but other consequences of this pandemic will not. We've already discussed the physical and emotional effects on quality of life, health, and well-being, but I'd like also to add spirituality. Spiritual care forms our vital component of our health management as people do recover, especially in terms of coping, coming to terms with illness, suffering, and bereavement and death. And also we need to heal as communities and networks of service and healthcare providers as we start to reopen our senior care, our daycare centers, our senior centers, and our support services. So there's a lot of healing that needs to be done. And everyone that we see now in our medical practice, if we ask about effects of COVID, we always receive a response, about how difficult it was and how difficult it has been. So, and healing is not restricted to older adults, but all of us who serve older adults, we've all been through this together as well in our own way. The trauma related to this pandemic runs deep, and our patients and our clients and our colleagues deserve this acknowledgement. And we will need to develop approaches and programs to address this trauma, because clearly this pandemic will be remembered as a tragedy. But the good news is we can work to relieve some of these consequences. Trauma-informed care is an approach developed for domestic violence initially, and our group has recently applied this approach to elder independent abuse. But it is a model which is flexible and can and should be applied to multiple traumatic situations that result in lasting stresses, including PTSD. Next slide, please. The core components or principles of trauma-informed care, and these that can be adapted to most interactions, including, I would point out, short interactions, such as maybe a driver delivering a meal and engaging in a short exchange. So it's worth consideration about how these tenets and how those of us in healthcare and community-based organizations can address these long-term effects. The tenets that we practice in trauma-informed care include safety, choice, collaboration, trustworthiness, and empowerment. And as I mentioned, there are many, many ways to build this, into our engagement, even in short engagements with the older adults that we serve. Okay, next slide, please. So to summarize, I've taken us through a whirlwind of long COVID, but hopefully I want to leave with a message of hope. Now that we are post-pandemic, we all need to prepare to address the new needs that our older adults would have, whether it's medical, mental health, social determinants of health, or caregiving. In addition to being concerned about changes in condition, and I know that Meals on Wheels is very serious about addressing changes in condition. We think that those moments will be on the rise for many older adults as we open up our world again. Trauma-informed care is one approach that can be built into our responses. So as our hopes now turn to a new version of what was normal in the past, I welcome any questions and look forward to our case discussion and look forward to our collaboration in our Gero Echo series. Thank you.
Does anybody have any questions for Dr. Gibbs? We do have a few minutes.
Nika, this is Holly. How do you want people to just to shout out kind of?
Yeah, you
Okay.
can just unmute yourself and ask a question, or you can put it in the chat.
Okay. I just want to comment. I want to thank you, Dr. Gibbs, because there's just a lot of compassion in your presentation, and it really comes through. Since I know you personally, I know that to be true, but it really comes through in the presentation. We're all of us on the phone are dealing with our clients every day who are experiencing these, but I'm just particularly touched by the way you've put this together and characterized it. So thank you for that. And I know that you are also a practicing doctor, even though you have a big job there, you also have clients, and that you at UCI, you have a really wonderful senior healthcare center as well. So
Thank you very much, Holly.
thank you for that.
Thank you.
Has Regeneron or any of the antibody cocktails, which are very limited in their use, of course, been helpful in alleviating any of the symptoms?
Well, we've had we've had many studies at UCI along the way, including monoclonal antibodies and so forth. I think in the beginning, at least with one of the studies, they thought that people were recovering a day or two sooner, but I'm not sure that's panned out in the final analysis. So I don't think there's been a silver bullet at this point.
Thank you.
Dr.
And we
Gibbs,
have, go ahead, Daryl.
I was just going to say again, Dr. Gibbs, thank you so much. This is a wonderful presentation. And I think what Holly said is so true. It's so filled with compassion. And the other thing I really appreciated is the devotion you're putting onto how the recovery will go, because that seems to me something we haven't talked about as much. And yet we know that that's going to be a very big undertaking.
Yes, thank you for that. I agree. I don't think the attention has really turned towards recovery yet. But hopefully California will continue to do well, and we can start this conversation. We know there's other parts of our country right now that are still experiencing surges and increases in illness. So really hoping we can maintain our lower levels of COVID and move into a recovery phase.
Oh, we do have a question. What do you think the new normal will look like?
Well, that's a bold question, right? I hope it looks better than the past looked. We know now that the digital divide is so important for our older adults. So, we need, to get back to the master plan for aging for California, because it's going to address a lot of these issues and hopefully improve the quality of life and access for services to our state's seniors. And anything we can do in that regard, I think would put us in a better position to weather the next pandemic, which it's not if, it will happen no matter what it is. So I'm hoping that, we'll be more digitally connected. I'm hoping that access for any of the social determinants, including healthcare, will continue to be easier and more efficient. And I'm just hoping that we have learned so much from this that we can do it better in the future.
Wonderful. Thank you all for your questions. If you do have any additional questions, please don't hesitate to write it in the chat and we can either email you with our answers or try to get to it at the end of the session. But we will go ahead and move on into our case presentation. So thank you again, Dr. Gibbs, for your didactic. And I believe Daryl is going to give us an overview of this case that was submitted. We're going to go ahead and give a quick summary, and then as a team of folks and Hub team, we'll go ahead and talk about the case together.
So thank you, Nika. The case is around a woman who was 82, who had previously been able to live alone and take care of herself. Her only relative lived out of town, and because the Meals on Wheels delivery person or the visits to the senior center were not happening on a regular basis, the change in condition was not picked up until there was a call from her relative from out of town who said, she's lost weight, she's stumbling, I'm hearing this on the phone, she doesn't sound herself. So my question is, how do you determine when it's time to do an early intervention? How can the people who are delivering the meals in a contactless manner, et cetera, pick up on that when we're so accustomed to body language, right, with the seniors we serve? So just around what should we be looking for when we can't really see someone?
Okay. Thank you so much, Daryl. So this is kind of the point where we could ask Daryl any follow-up questions. If you have any suggestions you have for questions posted about the client case and next steps, if you have anything to add to the case. This is the folks or the Hub can kind of weigh in.
I'm wondering how your services in general for Meals on Wheels have changed during the pandemic. I know you're serving many more clients and serving more meals, but it sounds like, yeah, how have the services changed? Are clients being seen less often, or again, just the contact between the clients and the volunteers are much less?
Yes, and I'm not in direct service at this point, but according to our survey results, the number of seniors has increased. That, of course, the senior centers have closed, so that socialization method is gone. And those seniors, if they're able, are doing drive-by pickup, grab and go. But for delivery, home delivery clients, it's mostly been contactless. So there's a whole protocol for the meal gets put down, there's a knock on the door, and then, you have to step back, you have to be away from senior, you're wearing a mask. Any of the normal social cues are missing in that. And I think that's been pretty much across the board, but others may know, have a bit more information on that.
Yeah, I would underscore what Daryl has said there. I'll also just say that, what some of our senior center directors have shared is they've seen the kind of decline that normally would happen over 1 year for people coming to the senior serve active senior center, active participants. The kind of decline, that they would normally see over 5 years. They're seeing that in 1 year, which just reinforces what you were saying. So I think for the people on this call, they're not necessarily getting their eyes on the senior the way they used to, because they actually may be leaving the meals at the door. They're stepping back. If they're homebound, stepping back. Participant may be opening the door. The participant may want them to go away altogether. and then open the door. So we're not, most of the programs probably are not going into the home. Normally our drivers might go in, even put the meals in the refrigerator or on the counter. might even do little helpful things like, change the batteries in their hearing aid or change a light bulb, those kinds of things. None of that's been happening. So I think relative to the question presented is, from your perspective as medical professionals, we're not necessarily able to pick up on this kind of change, weight loss and chronic fatigue. So, just whatever kinds of, I think, guidance that might be helpful to, our professionals that are on the phone could be helpful.
One of the things we've done to address this is we instituted a phone reassurance program where the same phone reassurance volunteer calls the same two clients twice a week, develops that relationships, gets feedback from the client, asks them what their needs are, makes referrals to whether it's transportation or pharmacies that deliver meals or deliver medicines for free. So we, suicide lines, mental health agencies. So we refer people, we gather that feedback and then refer agencies and organizations that can help them. And we found that to be really helpful, of course. And we also still get some feedback from our delivery volunteers, but the phone reassurance volunteers have become a critical part of what we do. And we're going to continue that even when we go back to 5 days of delivery.
Yeah, I mean, I guess.
Can I ask a? Oh.
Oh, go ahead, Geraldine.
Does the delivery person and the person that makes the phone call, is there some continuity between them? So if somebody hasn't picked up their meal from the day before, or there's 2 meals that happen to be still in the cooler at their door, is there a way for that delivery person to communicate with the phone person?
Our delivery people report back to our operations manager, and she then in turn reports it to the phone reassurance manager. And there's also a Google Docs document that the phone reassurance volunteers fill out. And then the phone reassurance manager either talks to that volunteer or reviews the Google Doc, so that there is continuity and there's a documented trail of what the actions were taken. So if a volunteer reports, a delivery volunteer reports a problem, it gets to the phone reassurance manager, and if a phone reassurance volunteer reports a problem and either talks to the manager or puts it into the Google Doc. So yeah, there are systems in place.
That sounds like a wonderful program. I wonder, do the folks that are calling these clients, do they have a specific set of questions? So do they like ask about falls or?
No, we have and those we have not, well, every client is provided a resource list, but yeah, there's a script, there are guidelines, there are questions, they change from time to time. Recently, we started delivering fruit again, fresh fruit. And we went, hey, you like bananas or apples or oranges better? And so we absolutely do have provided questions. And we've also done some really interesting training called Beautiful Questions, which teaches the phone reassurance volunteers to kind of ask open-ended questions and start a conversation so it's not clinical or checking up, it's developing a relationship.
It's wonderful, thank you.
Yeah, along those lines, I would just hope that if we all know what people are likely to experience, such as if we know there's a woman living alone and we know that the rates of anxiety and depression reach 40% if that person has a chronic condition, then we can be more sensitive to looking out for that and understanding that probably exists. So perhaps we can tailor our responses to the fact that we know that there's a high percentage of post-COVID problems, including mental health issues. and address our responses that way. So if the drivers have, 1 minute or 30 seconds with somebody and they know this and they're aware of what's probably going on, then maybe they can more efficiently be able to pick this up.
Yeah. I think these phone reassurance initiatives have been really, a lot of them have cropped up, accelerated by, the pandemic. Meals on Wheels providers normally will do in-home assessments or at-door assessments, and then maybe intersperse them with telephonic assessments. So they're doing them maybe quarterly, depending on the program. There's lots of different protocols. I know we developed a program kind of similar to what Chris identified. And I'm just curious if people wouldn't mind in the chat, if you have put in a telephonic, any kind of reassurance or friendly caller, we call ours friendly caller program, during COVID, or if you extended one, if you could put your a comment in the chat to everybody with your name and your program name, just to let us know, because I think from for the association's perspective, it would be helpful to know and kind of who may have best practices and maybe willing to share them with other Meals on Wheels programs as well.
My question is, do you guys deliver any kind of resources or even like a paper survey, like with the meals, for example, or something that can be given to the senior with their meals?
Yeah, we do. We do surveys regularly. One of the surveys we did was about who had been vaccinated. So every client got a vaccination survey, and the ones who didn't answer got telephone follow-ups. And about 85% of our clients have been vaccinated at this point, and we're closing in on getting it. We'll probably get it to about 92 is my guess. 10% are refusing right now. But so yeah, we do distribute surveys on a regular basis.
Okay, wonderful, thank you. Would anybody else like to weigh in or pose any other questions for our hub team or those on the line?
Hi, yes, I have a question for Dr. Gibbs. Everything that I'm a big research nerd, everything that I've read and gone through and heard states that we should be okay after winter. That winter is going to be a little iffy, but as soon as winter's over and by spring, we should be completely out of this. Is that true?
Well, I think we do expect a surge in the fall and the winter. I think most people believe that this will never ever really ever go away. And in fact, the vaccine companies are developing booster shots. So I think this will always be something that exists, but as a society through vaccinations, we will maintain control over this going into the next year. We actually anticipated in Orange County a surge after spring break, which we're actually not experiencing, gratefully so. But I would agree with you. We do expect probably a fairly good summer, moving into some more cases in the fall and the winter, and then tapering off as we get more and more and more people vaccinated.
Thank you so much.
And we have a lot of people answering your question, Holly, in the chat. Those are recorded, so I can also send them to you.
Actually, it's just wonderful to see how many programs there are. And I saw that San Diego participated with USD's nursing. We did too with UCI and through multiple of the senior serving programs in Orange County did as well. So it's been really a great opportunity, very robust for collaborations and people, groups just coming together to say, how can we support each other in supporting, those that are at risk.
Mm-hmm. And we had the UCI, in collaboration with our nursing program, we created the ASSIST program, which is assisting and supporting socially isolated seniors via telephone. And, we did partner with UL, Meals on Wheels Orange County, and a few of our other partner organizations throughout Orange County to provide that telephone check-in service. So it's wonderful to see that so many of you all are doing the same thing. I think Danielle has a question.
Great, thank you. And thanks so much, Dr. Gibbs. This is a really great presentation and good research. I have a question. So right now it feels like a lot of the clients are fully vaccinated, but still waiting. It's almost like waiting for a new variant to come out. So I guess the question, any advice on, at this point, how to either encourage or discourage to be a little bit less isolated?
Right. And what we've seen is that people are still hesitant to come in for medical care in some cases. But, honestly, the variants haven't played a huge role. I can only speak for Orange County, but I believe California in general is doing very well. Knowing that our healthcare workers are virtually over 90% vaccinated, knowing that everything we put into place, we're telling people that it's really safe to come in for medical care. And I don't know how soon everyone can open up senior centers or daycare centers or congregate programs or lunch programs and so forth and so on. And you may have more information than I do about that. But I think at the point when we do, I'm hopeful. I think we could probably tell seniors that it's okay. It's okay to go out and involve yourself in these activities again, especially if our rates remain low, especially if people are vaccinated, especially if we continue to be careful with masking and so forth. I think we have to. I think we have to start recovering and getting out into the world again.
Thank you.
Wonderful. Does anybody have any last minute questions before we kind of move on into closeout? And any last minute questions about the case that was presented? Okay, thank you so much, Daryl, for presenting that case and giving us an overview. Hopefully we're able to answer the questions. So in closing, we do have, we will send this PowerPoint out to everybody right after this presentation. So you'll get a PDF copy. But if you do want CE credits, please make sure that you do fill out the CE form that is going to be at this link. I'll also send that via email. We always encourage your evaluations for our continuous quality improvement efforts. And you can also submit suggested topics for future ECHO sessions. And this presentation and links will be sent again in the follow-up emails for you. You will receive a certificate if you do want a CE credit. So you will receive that certificate via the email that you included in your registration. Our next session is in 2 weeks on May 7th, and it's going to be focusing on mental health in older adults in social isolation, and that will be presented by one of our HUB team members, Geraldine Date. So we look forward to seeing you in 2 weeks. If you do have any other questions, please don't hesitate to reach out via this email, or you can just respond to the email that I will send you after this presentation. Thank you guys so much for joining us today. And again, we hope to see you in 2 weeks.
Thank you, Nika. Thank you, Dr. Gibbs.
Thank
Wonderful presentation.
Yeah.
Thank you, everyone.
Thank you,
Great information.
Thank you. That was good.
Thank Thank you. Appreciate it. Thank you.